Advisor in Samarth Life Sciences. Over to Dr. Divya for introduction of our distinguished and revered panelists for today's webinar.
Okay, thank you, Prashant. Good evening to all. Hope everyone is doing safe and well. As Prashant has said, myself, Dr. Divya Bhojwani from Medical Affairs teams of Samarth Life Sciences, and on behalf of my entire Samarth family, I welcome you all for today's interconnect on adrenal medicine, which will be delivered by our key speaker, Dr. Aniket Kumboskar and Dr. Vijay Jaiswal. Dr. Aniket Kumboskar, consultant pediatric and adolescent endocrinologist at Grow Kids Endocrine Clinic in Kolhapur and Sangli. He is also associated with Department of Pediatrics at Bharti Hospital Sangli as an associate professor. After completing his MBBS from MUHS Nasik, he went on for a fellowship in pediatric oncology from Birmingham Children's Hospital, UK. He has been an active member for research societies like Indian Society of Pediatric Endocrinology and many more. Apart from his clinical practice, he also has keen interest in academics and has over 10 years of experience in teaching graduates and postgraduates. He has also been a faculty for various pediatric workshops like Pedicon and many. He has attended various national conferences and conducted workshops on pediatric growth charts and endocrinology. And for today's webinar, he will share his insights on adrenal insufficiency beyond CAH. Another key speaker we have for today's webinar is Dr. Vijay Jaiswal. Dr. Vijay Jaiswal is head at Department of Advanced Pediatrics and Neonatology at LLRM Medical College, Meerut. He specializes in pediatric endocrinology and diabetology. He is a founder of a help group for children living with diabetes called SWEET. He was instrumental in starting universal congenital hypothyroid screening at Medical College in Meerut. He is an executive member of Growth Society of India. He has been a secretary for Indian Academic of Pediatrics Meerut. He has received Best Thesis Award at AIMS 2018 as a guide. Apart from his achievement, he has over 15 international and national research publications. For today, he will be speaking on corticosteroid dosing in CH, walking the tightrope. We are glad to have you here, sir, and looking forward for a great session. So I welcome you, sir, and hand over the proceedings to Dr. Aniket.
Okay. Good evening, everyone.
Good evening.
So, should I start my topic?
Yeah, yes, sir. Please.
Can you see my presentation?
Yes, sir. It is there.
Okay. So, basically today we will cover adrenal disorders in pediatrics, and all of us know that CAH is the most common adrenal disorder which we encounter. But today I will be focusing more on adrenal problems which are not related to CAH. So to understand the importance of identifying these disorders in time, and to start the management in time to prevent the life-threatening complications of adrenal crisis. So the thing, we'll just minimize this screen. Okay. So what is your response to emergency? As we have taught in basic sciences, that is either fight or flight. And the most important endocrine response organ for this any stress situation in for a physiological response is adrenal glands. So we'll first understand basics of this, and then we will go ahead with the pathophysiology. So what is the HPA axis? That is hypothalamo pituitary adrenal axis. So any stress will cause hypothalamus to secrete CRH, that is corticotropin releasing hormone, and CRH will act further on pituitary gland, anterior pituitary gland specifically, and then pituitary gland will produce ACTH, that is adrenocorticotropic hormone, and this is this hormone which will act on adrenal cortex for to produce cortisol. Now this is a diurnal rhythm of cortisol, which corresponds to pulsatile secretion of ACTH. So you can see the highest concentration is around morning 8 a.m. to 9 a.m. And then over the day it gradually falls, and it is lowest around midnight, which is less than 2 microgram per deciliter. And then again, it gradually rises throughout the night to have a peak in the morning. Now, any stress leads to this increase in the ACTH secretion, which will lead to further change in this diurnal rhythm of cortisol secretion, as you can see in this graph. And most potent stress-induced stimulators of CRH are IL-1, IL-6, and TNF. So I have divided this talk into these specific learning objectives. That is, what first we will see what is adrenal insufficiency, then classification, causes, approach, evaluation, and management. So what is adrenal insufficiency? It is a failure to produce adequate cortisol with or without mineralocorticoid and adrenal androgen defect. And if you want to classify this, then you can classify into 3 main categories. That is primary. Primary means adrenal gland is defective and it is not able to produce adequate cortisol and androgens. Pituitary related, that any defect in the pituitary glands, such as any lesion around pituitary which causes destruction of pituitary, like craniopharyngioma, or any CNS tumor, which can lead to pituitary structural problem, also can lead to secondary adrenal insufficiency. And third is hypothalamic, which we will understand it when we discuss the most common cause of adrenal insufficiency in children, which is due to exogenous corticosteroid therapy. So when to suspect adrenal insufficiency, specifically newborn and infancy. So any child who is presenting with failure to thrive, recurrent vomiting, hypoglycemias, poor feeding, and always it will mimic clinical presentation of sepsis. So sepsis, although sepsis is the most common cause of presentation of these symptoms, always keep in mind that it can be adrenal insufficiency which can present like this. Now we will understand this table or causes according to different etiologies. Okay. So either it is adrenal dysgenesis or hypoplasia, or there is adrenal destruction, or there is impaired steroidogenesis. So what are the causes of dysgenesis or hypoplasia, which is also called as AHC, that is adrenal hypoplasia congenita, which is because of either SF1 defect, gene defect, DAX1, or ACTH receptor problems. Adrenal destruction generally happens in childhood or in adulthood, which is because of most common autoimmune process or adrenal leukodystrophy, infections like tuberculosis, metastasis, and amyloidosis. Impaired steroidogenesis, so either cholesterol metabolism defect like Smith-Lemli-Optich syndrome or beta lipoproteinemia, then steroid biosynthesis defect like STAR, mitochondrial DNA deletion, or CH. So if you understand this table, it is very easy. In the next slide, I am going to tell you how to divide these causes according to age groups. So this is an approach in which you can determine most common causes with respect to age groups. So less than 2 years with both deficiency of glucocorticoid and mineralocorticoid. Generally, it is FGD or STAR defect. Glucocorticoid deficiency only with preservation of mineralocorticoid levels. it is CH or AHC or other biosynthetic defect. Then in 2 to 20 years age group, if glucocorticoid is deficient but mineralocorticoid is normal, then it is either adrenoleukodystrophy, familial glucocorticoid deficiency, or AAA syndrome. If both are deficient in this age group, then again ALD or APS1, autoimmune or infection. So you can see that these disorders are overlapping in different age groups, but this is the general broad outline by which you can suspect the disorders. And more than 20 years, it is most common is again autoimmune infections, infiltrations, and APS1 or 2. Now, the most important test by which we differentiate adrenal insufficiency or to diagnose deficiency in cortisol secretion is ACTH stimulation test, or also called as synectin test. So the dose in neonates is 15 microgram per kg. Up to 2 years, it is 125 microgram. Over 2 years, 250 microgram. Although in certain guidelines, the universal dose, that is 250, is the recommended dose for all age groups according to certain guidelines. So if you give this stimulation, after this stimulation, cortisol should rise above 18 microgram per deciliter. And if it rises beyond that, then it practically rules out adrenal insufficiency. Then treatment part is hydrocortisone, glucocorticoid of choice, and cortisol production in normal subjects is 5.7 to 7.4 milligram per meter square per day. And replacement dose of oral hydrocortisone is around 10 to 12 milligram per meter square per day. This is a general guideline of dosages. Dr. Vijay Jaiswal will cover the replacement dose in CH specifically, which is totally a different and difficult part of management. And he will focus on the replacement dosages according to different types of CH. Then higher doses are required generally for primary adrenal insufficiency than secondary. That is, if it is because of pituitary problem or hypothalamic dysfunction, the dosages required are less. How do you monitor? Monitoring of glucocorticoid replacement therapy is by basically a clinical judgment. So there is no test which will help you to identify or to monitor exactly the levels like plasma ACTH levels or cortisol taker or urinary free cortisol or salivary cortisol. Even though these are guides to our clinical judgment, but the most important thing to monitor or to replace the dosages or to adjust the dosages is growth monitoring, that is weight and height monitoring, and clinical parameters. Plasma renin activity is one parameter which is important when you monitor mineralocorticoid replacement, and we have to maintain it in the upper normal range when we are giving fludrocortisone as a replacement therapy for mineralocorticoid deficiency. So basically, fatigue, nausea, myalgia, lack of energy, and weight loss will suggest under replacement, and weight gain, central obesity, osteoporosis, impaired glucose tolerance, and hypertension will suggest over treatment. So rather than wasting time, I think we will go to clinical cases directly so that we can understand how the presentation of these different disorders is and how to deal with them. So this is a 4-day baby who was born of non-consanguineous marriage. That baby was presented with hypoglycemic convulsions. Hyperpigmentation was noticed by pediatrician. There was some dysmorphism, skeletal deformities, and limb deformities were present. When the baby was admitted in NICU, it was having severe dehydration. There was significant generalized hyperpigmentation. Along with that, there were certain features which were very evident, like micropenis. There was bilateral cryptorchidism. Microcephaly was present, and blood sugar was 26 when on admission. So any child with these clinical features, with hypoglycemia, with significant dehydration in first few weeks of life, we should always suspect adrenal cause. And primary, this suggests primary adrenal insufficiency because this baby has hyperpigmentation. That means ACTH levels are higher. So we will discuss in a bit why patients with adrenal insufficiency, primary adrenal insufficiency present with hyperpigmentation is, along with ACTH, the corticotropin releasing hormone will also stimulate production or secretion of MSH, that is melanocyte stimulating hormone. And this excess high level of MSH leads to hyperpigmentation in these patients. So in such a young child, what are the possible causes? The most common cause which we will always think is CH. Then other causes like AHC, as we discussed, adrenal hypoplasia causes like SF1, DAX1, STAR, or other disorders like XP21. Now we will see the reports. 17-hydroxyprogesterone in this child was in fact low, 0.26. Sodium was low, 133. Hyponatremia was there. Potassium was borderlinely elevated. Testosterone, total testosterone level was low. ACTH was sky high, that is above 1250. Cortisol was very low. And this sample was taken during hypoglycemia. So growth hormone response to hypoglycemia was adequate. So you can see that these reports are definitely suggestive of primary adrenal insufficiency. And specifically, this child is deficient in both glucocorticoid, that is cortisol, as well as mineralocorticoid because of this electrolyte picture. And when you combine this puzzle of adrenal insufficiency with all these dysmorphic features, one diagnosis which comes to mind is IMAGE syndrome, which is acronym for intrauterine growth restriction, metaphyseal dysplasia, adrenal hypoplasia congenita, and genitourinary abnormalities, specifically in males. There is no formal clinical diagnostic criteria yet defined for IMAGE syndrome. It is a very rare disorder. And what are the findings? That is, you get IUGR, postnatal growth deficiency, adrenal hypoplasia congenita, along with mineralocorticoid deficiency features. And sometimes, if it is a mild disorder, they can present even in later childhood. Late onset adrenal insufficiency can be precipitated by stress or illness or surgery. Genital abnormalities include unilateral, bilateral, undescended testes, hypospadias, micropenis, and cornea. Imaging findings are suggestive of metaphyseal or epiphyseal dysplasia, mesomelia, osteopenia, and delayed bone age. Skeletal abnormalities are there and which are age dependent and can be absent or subtle in these patients. Adrenal imaging that suggests small or normal size gland in contrast to enlarged glands as seen in CH. So typically a CDKN1C pathogenic variant causing IMAGE syndrome is inherited as autosomal dominant. However, only maternal transmission of the pathogenic variant results in IMAGE syndrome. So you can see that this is more like a imprinting disorder. Each child of a woman with heterozygous pathogenic CDKN1C has 50% chance of inheriting the variant and being affected. Each child of a man with heterozygous CDKN1C variant has 50% chance of inheriting the variant, but it is clinically not affected or it is unaffected. If pathogenic variant has been identified in an affected family member, prenatal testing is possible for pregnancies at increased risk. We'll go to the next case now. So this is a 4-year-old boy presented with hyperpigmentation since infancy, failure to thrive, and hypoglycemic seizures. There was no lacrima, that is the tears were present. There was no history of dysphagia. There was no precocity. Blood pressure was 90/50, which is low. Basal ACTH was very high, 3,430. Cortisol was low. Sodium was 132. Potassium was 3.3. 17 OHP was 0.18. And PRA was 1.2. Very long chain fatty acid assay was normal. So you can see this is onset very early, 1 year, suggestive of glucocorticoid deficiency, but mineralocorticoids were preserved. So most likely diagnosis in this child is familial glucocorticoid deficiency. So what is this familial glucocorticoid deficiency? It is a phenomenon of ACTH resistance, and there are three types actually. FGD1, in which we get mutations in MC2R receptor or ACTH receptor. FGD2, we get mutations in MRAP gene, which impairs MC2R receptor transport from endoplasmic reticulum to the surface. And FGD3, in which we don't get any genetic or mutational analysis, we don't get any specific pathogenic known variant in these patients. So actually, this patient was having defect or mutation in the MRAP gene. 4-year-old boy, again, hyperpigmentation, failure to thrive, hypoglycemic seizures were present. And in this child, there was very interesting features of lacrima, that is absent tears. And there was history of dysphagia also. Stimulated ACTH was, ACTH stimulated cortisol was very low, basal ACTH very high, sodium potassium was normal, PRA was normal, and esophageal manometry was suggestive of achalasia cardia. So age of onset, around 4 years, glucocorticoid deficient, milocorticoid preserved, with history of lacrima and achalasia. So this is AAA syndrome, and the genetic analysis will show us homozygous AAA splice mutation in exon 1. So AAA syndrome is mutation in this gene on chromosome 12q13. It encodes for lacrima, achalasia, and adrenal insufficiency neurological disorders protein, which is also called as albin protein. And lacrima is the earliest and most consistent feature in these patients. Neurological manifestations may occur in later age. Now we will go again to basics of classification of corticosteroids. So short acting are hydrocortisone, cortisone, intermediate acting like prednisolone, methylprednisolone, triamcinolone. Long acting, we all know that it is either betamethasone or dexamethasone. And then relative potency of these steroids is very important to understand. So potency is defined with respect to anti-inflammatory and mineralocorticoid and growth inhibiting properties. So hydrocortisone has got anti-inflammatory property, which is equivalent to endogenous cortisol production, and growth inhibition effect is also very less. Cortisone is slightly less as compared to hydrocortisone. If you see prednisolone and prednisone, the anti-inflammatory properties are 4 times more than hydrocortisone, and mineralocorticoid effect is slightly less, but there is significant growth inhibition effect with prednisolone. And dexamethasone and betamethasone, these are the most potent corticosteroids, which with respect to anti-inflammatory dose, they have very less mineralocorticoid activity, and but the growth inhibitory profile of these steroids is very high. And that's why whenever you get a child with any patient with meningitis or increased intracranial tension because of any inflammatory process, the drug of choice is dexamethasone, because it has got zero mineralocorticoid effect and potent anti-inflammatory effect. Fludrocortisone, you can see it is the having mineralocorticoid potency of 125 times. So very potent artificial mineralocorticoid, which is the only one which we have available for replacement of mineralocorticoid therapy. Very important thing slide I wanted to include in this talk is this is a very dangerous drug, and this is a very dangerous preparation, because it has led to second Cushing's exogenous Cushing syndrome and adrenal insufficiency and mortality in many patients I have seen because of use of this drug for a prolonged duration. And there is no indication whatsoever to give this medicine in pediatrics, because it is not indicated in any inflammatory process, because the potency is very high and growth suppression is very high. So it should not be, never should be used for chronic indications. So when any patient on steroid therapy, all of you know this, how to monitor them, but I just included a slide so that you know what are the things you monitor. That is weight, height every visit, blood pressure every visit, clinical features, blood sugar every 6 monthly, electrolyte 6 monthly, bone mineral density, lipid profile every yearly, and eye examination for cataract, glaucoma every year. So just a few points to prevent secondary adrenal insufficiency because of glucocorticoid use is to use only if necessary, use steroid with lowest potency, use lowest effective dose, taper the dose as early as possible, switch to alternate regime as early as possible. So whenever you any patient is on long-term steroid or any steroid therapy, this is a way in which we have to taper to prevent adrenal crisis because of HPA axis suppression. So if it is less than 2 weeks duration, you can stop abruptly. I'm sorry for this. It is not more than, it is less than 2 weeks. 2 weeks to 1 month, taper over 7 days. If it is more than 1 month therapy, we have to decrease very gradually by 1/4 of total dose every week till reaching physiological dose. That is 10 to 12 milligram per meter square. Then if the disease flares up, we have to increase the dose. Like suppose a patient is on JI is on therapy and there is increase in the inflammation, sometimes, or nephrotic syndrome in relapse, we have to increase the dose. But if patient is stable, we can gradually go on decreasing by 1/4 every month. And when patient is on physiological replacement, we have to check morning cortisol. If it is less than 3, we have to continue replacing. If it is more than 20, we can stop the treatment. So all patients using corticosteroid therapy are at risk of adrenal insufficiency, and clinicians should inform patients about the risk and symptoms of adrenal insufficiency. Consider testing patients after cessation of high-dose long-term treatment, and display a low threshold for testing, especially in those patients with non-specific symptoms after cessation. So this is just summary that supraphysiological dose to physiological dose, that is 8 to 10. Then we can stop evening dose and then stop afternoon dose and morning dose only as a 5 milligram per meter square per day, and stop and give stress schedule only after that. So it is not very rare to get iatrogenic adrenal insufficiency because of glucocorticoid use, and the risk of this is associated with type, dose, and duration. We have to inform the patients about risk and symptoms, and we have to test 3 months after cessation of dose again to ensure that patient is producing adequate cortisol. So this is the stress dosing for glucocorticoids in various situations: mild, moderate, severe, and very severe. So in mild illness, no stress dosing is required. In moderate, it is 30 milligram per meter square per day, that is 3 times maintenance. Severe, 50 milligram, and very severe, like surgery, shock, critical illness, adrenal crisis, we have to go as high as 100 milligram per meter square per day to treat these patients. What is new? So now in some patients, the hydrocortisone is used as an infusion, but not commonly or widespread use is there. And modified release hydrocortisone is also underway for investigation for replacement, because current therapy with hydrocortisone is not matching the physiological requirements. So take home message: high index of clinical suspicion is required to identify these cases. Early diagnosis and treatment is key to success, and etiological diagnosis, genetic counseling, and monitoring is very important. Thank you.
Thank you, Dr. Aniket. I think we'll have Q&A at the end of the session, and we can have Dr. Vijay session now.
Okay.
Over to you, sir.
Yeah, thank you. Thank you, Dr. Aniket. It was really an very good presentation with good cases and very well explained. There can be some repetition in the thought because the topic is same, the hormone is same, but yes, I'm going to talk about mainly focusing on the CAH, that how this adrenal corticosteroid to be given. So just I'm sharing my screen. Yes, can you see this screen?
No, sir, not yet. Not yet, sir.
Okay, just hold on. Just 1 second.
Yes.
Yes. Yes, now it's visible.
No, no, sir, not yet.
Where I went wrong. I just share screen. I am on that.
Yeah, yeah. So you can close all the unwanted tabs, like the extra tabs you might have open.
Okay,
Then
just
it can work, I guess.
one this Zoom is there.
No, sir, just go to share screen.
Yeah.
Now open basic.
Yes, yes. Basic, yes.
In that, open all the windows at the below you will see. Or if you are seeing directly presentation, click on there.
A select window, yes. Application that you want to share. Yes.
Ah, yes. You'll find presentation, click there.
No, that.
Sir, first open the presentation. Don't close the
Yes, yes,
presentation.
I have opened the presentation. Yes.
Then on the share, you will get the presentation, sir. On the when you click on the share button.
Okay. Hold on. Share. No. Yes, I have opened that. Some technical problem is there. Yeah, I have opened this. Yes, and share. Yes, share screen.
Yes, sir.
Yes, yes, now it's coming. Yes, sorry. There was some. Now you can see.
Yes, sir.
Yeah, yes, sir, it is there.
Yes, thank you. And I'm sorry for these technical glitches.
No
So
problem, sir.
again, just I'm going to continue the talk in continuation with adrenal insufficiency. What can be the other things that we have to take care? Particularly, I'm going to stress upon corticosteroid therapy in CAH. So it is very easy to say, but it is very difficult to be on the physiologically or very rational basis. And I'll tell you why it is so. So it is really a walking on a tightrope that you have to act, lot of balancing act to quantify that. So what is our goal in therapy in CAS? That goal of therapy is to reduce excessive androgen secretion by replacing the deficient hormones. Proper treatment with glucocorticoids prevents adrenal crisis and virilization, allowing normal growth and development. Clinical management of classic CAH is difficult balance between hyperandrogenism at one side and hypercortisolism at another. Undesirable side effects with even minor degree of over treatment or under treatment are going to be there. So Dr. Aniket has done my job easy and he's enumerated that how cortisol is going to affect the various organs. And the first thing is that this is a hormone of emergency. Either the body have to fight or the body has to flight. So what endogenous corticosteroid, what is the physiology? That endogenous secretory rate of cortisol is very less, that is 6 to 8 milligram per meter square per day. But data is not available for infants and children under 5 years. Normal adrenocortical secretion has a circadian rhythm, we all know, with levels low at onset of sleep, rising between 2 a.m. to 4 a.m. and peaking at 8 a.m. in the morning. So that's why we usually prefer that 8 a.m. cortisol level usually to say for insufficiency. It is crucial to mimic the normal endogenous production of glucocorticoids. Existing glucocorticoid therapy is non-physiological and may contribute to adverse outcome. So the range of normal values varies considerably, indicating that therapy must be tailored for the same disease and individualized for each patient to achieve optimal results. Programmed infusion of hydrocortisone delivered in a circadian fashion to poorly controlled CAH patient resulted in nearly normal ACTH and 17 OHP. So we'll discuss in the coming slide whether it is feasible or not, or this is a potential therapy. So further studies are needed to determine whether more physiological cortisol replacement could improve long-term clinical outcome. The circadian rhythm of cortisol is important for health in humans, and we can observe that there can be deleterious effect when this rhythm is disrupted. And very common example I'm taking, that many of the symptoms that patient with adrenal insufficiency complaints such as fatigue, sleep disturbance, and poor concentration are seen when the cortisol circadian rhythm is disrupted, and you can see in jet lag. So it is therefore a reasonable hypothesis that replacing cortisol in a circadian manner should be superior to current therapy. So this should be no less true in pediatric than adult population, and the sleep cycle may be more important in developing individual than adult. So what should be the choice of glucocorticoid? This is $1 million question. So during childhood, there is no ambiguity that preferred glucocorticoid is hydrocortisone. So why hydrocortisone is preferred? That hydrocortisone is preferred because it's short half-life and minimizes the adverse effect of more potent, longer-acting glucocorticoids, especially growth suppression. For initial reduction of markedly elevated adrenal hormone level in infancy, one may exceed the recommended glucocorticoid dose. Rather, it is usually required supraphysiological dose for the initial suppression. But it is important to rapidly reduce the dose when the target steroid levels are achieved. So this is also important. Attempts to completely normalize 17 OSP level typically result in overtreatment. So our aim should be focused on clinical improvement and other biochemical criteria, not only the normal level of 17 OSP. If you are going to target that, rather you are going to overtreat, or steroid toxicity is bound to happen. So prednisolone and dexamethasone treatment are effective in suppressing adrenal androgens in children with CAH. But these are more potent drugs, are more likely to impede statural growth and cannot be routinely. So you remember the previous slide shown by Dr. Aniket, that was a very beautiful slide, and he has shown the various effects of corticosteroids in different terms. At or near completion of linear growth, yes, long-acting glucocorticoids may be used, though hydrocortisone remains a treatment option for always. Yes, so Dr. Aniket has given one glimpse that what can be the newer armamentarium, that hormonal profiles, so modified release of hydrocortisone. So hormonal profiles during therapy with new modified release hydrocortisone, that is chronocort, compared to conventional hydrocortisone in patient with CAH. And what studies have proved that this can be a promising new treatment for CAH. But what was the problem? That overnight adrenal androgen were well controlled, but rose in the afternoon with once daily dosing. So the thought was that if you are going to give modified release hydrocortisone, probably it is going to do job for 24 hours, but it is not like that. So still it is not the optimal therapy for replacement. Yes, again the new concept that like insulin, that is 24 hours infusion, here continuous subcutaneous hydrocortisone infusion is a safe and well tolerated modality of cortisol replacement. It effectively approximates physiologic cortisol secretion in patient with classic CAH, poorly controlled on conventional therapy. But there is a rider that it is not easy to maintain. And though it has been shown that improved adrenal steroid control and positive effect on health related quality of life suggests that continuous subcutaneous hydrocortisone infusion should be considered a treatment option for classic CAH. But since we don't have any robust model for that, so again, this is in a conceptual phase or experimental phase. Probably in next 2 decades or 3, so we will be able to modify the thing and will be more friendly to do that. So long-term effect on established comorbidities require further study. So still we can't say that this is a good option. But yes, it is a potential option for sure. Now coming to the hydrocortisone versus prednisolone, why we are sticking for hydrocortisone in pediatric population, this is really important. And I have gone through many studies. So they have compared about 12 studies for hydrocortisone and prednisolone, and the outcome was assessed on the basis of 17 OSP, androstenedione, body mass index, and bone mineral density. So in terms of 17 OSP levels, most studies did not find any significant difference between treatment groups. However, some has contradictory results that it is going to, but obviously, if you are going to see the side effects of prednisolone, it is really horrible. So prednisolone versus hydrocortisone growth suppressive effect. So you can see in this study, prednisolone has unknown growth suppressing effect related to other steroid. And what is the value? That growth suppression relative potency for prednisolone to hydrocortisone is about 15 times. So it's quite high. So treatment for height in CH, yes. So if we know that these patients are going to compromise with some height, whether it will be prudent to give growth hormone, so a big no. So normal height can be achieved in CH with judicious use of standard glucocorticoid and mineralocorticoid therapies. And height enhancing drugs are not recommended for individual whose height is or expected to be very short, that is minus 2.25 standard deviation. Then only we have to think alternative therapy for augmentation of height. Otherwise, if we are going to balance the glucocorticoid and mineralocorticoid therapy and proper monitoring, rather any growth augmentation therapy is not needed. Now coming to the second, that hydrocortisone equivalent dose, why there is juggling, that why there should be this type of tight balancing. So there is a significant difference in the effect on the final height was seen in the corticosteroids used for treatment of CAS. Because hydrocortisone equivalent doses correspond to anti-inflammatory and not to the androgen and growth suppressant effect. So the meaning of equivalent doses in the context of CAS remain unclear in some aspects. So again, so how we are going to measure the things, what efficacy you want to see, so that is going to be there. So what are the practice guidelines say that how to go about in CAH? So what are the recommendation for glucocorticoids? So recommendation is that maintenance therapy with hydrocortisone tablet in growing patient with classic CAS. So they have given. And what is they have told against any, so that is tablet form should be given, no suspension and chronic use of long-acting potent glucocorticoid in growing patient to be given. And recommendation, they recommended that patient for signs of glucocorticoid excess as well as for signs of inadequate androgen suppression, they should be monitored. So what is the maintenance dose? Dr. Aniket has also highlighted the thing that glucocorticoid, these are the tablet formulation 10 to 15 milligram per meter square per day. So divided doses are required, that is 3 times a day. Fluoricort, that is fixed dose usually in a range of 50 milligram to 50 microgram to 200 microgram per day, 1 to 2 times per day. And initially that is 1 to 2 gram per day of salt to be given. And what about in the grown up? So here that is the dose is hydrocortisone 15 to 25 milligram per day, that is divided into 2 to 3 daily doses. Prednisolone, because the height has been achieved, 5 to 7.5 milligram per day in 2 divided doses. Prednisolone 4 to 6 milligram per day in 2 divided doses. So stress dosing, Dr. Aniket has already pointed out that what it means, and he has beautifully that for minor illness, you don't have to change any dose. So what are the things that patient with severe form of 21 hydroxylase deficiency are unable to produce? So why there is need of stress dosing? So these are the patients who are unable to produce a sufficient cortisol response to physical stress, such as febrile illness, gastroenteritis, with dehydration, surgery, or trauma, and they require increased dosing of glucocorticoids. So maintenance dose should be resumed when the patient is stable. So this is not for a very long period of time. Exercise and psychological stress, for example, anxiety and examination, do not require any increased glucocorticoid dosing. So this you can see that is ready reckoner, that is suggested stress dose of glucocorticoid infants and preschool 25 milligram, school age children about 50, and adults. So this is a round off type of things. And if you are going to say, so 3 to 5 times we can increase the dose for a short period of time till that stress factor is there. A bit about treatment or glucocorticoid replacement in non-classical variety of CAH. So the suggestion, what guidelines say, that inappropriately early onset and rapid progression of puberty or bone age and adolescent patient with overt virilization may require this corticosteroid therapy. Now, since the disease will need corticosteroid therapy for a long time, so obviously, so it is not devoid of complications. So what complications or what are the things you have to monitor during the follow-up? It is important that close monitoring for atherogenic Cushing syndrome in all glucocorticoid treated patients. And suggestion is against that routinely we don't have to do bone mineral density in the children who are on glucocorticoid therapy unless and until there are indication of pathological fracture or something like that. Adrenal imaging should also be reserved for those patients who have an atypical clinical or biochemical course. Then only we have to go for that. Yes, a bit about, because puberty is all different ball game together, and this is going to happen that puberty alteration in the cortisol pharmacokinetics is going to be there. So there can be some variation in the dose requirement, and that can be on individual basis. So it is prudent to monitor very closely during the effect and deficiency, both, that is side effects as well as deficiencies of glucocorticoids in puberty. So what can be the dose? That adult height of CAH patient correlates negatively with the dose of glucocorticoid administered in the early puberty. Patients treated with less than 20 milligram hydrocort per meter square at start of puberty are significantly taller than those who were given higher hydrocortisone doses. Therefore, as with younger patients, it is important during puberty to treat with the lowest possible dose. And what is the key? The key is the monitoring. Yes, mineralocorticoid, a bit about that. It is going to have steroid sparing effect. So we should also add this thing also. Yes. And what are the recommendations? What endocrine societies say that how to monitor these children? That monitoring by consistently timed hormone measurement, and endogenous adrenal steroid secretion not be completely suppressed to avoid adverse effect of overtreatment. This is important. And in all setting, monitoring of height, weight, and physical examination, as well as annual bone age assessment, is suggested after 2 years of commencement of therapy. Yes, so we have to monitor these patients. So what can be, so there is any fixed protocol, or what can be the good or gold standard biomarker? Is there any exist in CAH patient? So no. The lack of significant biomarkers stem directly from the particular patterns of hydrocortisone pharmacokinetics. Volume distribution, plasmatic protein binding, P450 mediated drug interaction, all influence the inter-individual variability. So there are so many confounding factors. That's why there is no fixed biomarker for that. So what is current? What we have to do? So current biomarkers such as cortisolemia, that is excessive cortisol or low cortisol, ACTH level, that is whether it is oversuppressed, and 24 hours urinary profiles prove to lack of reliability. So we don't have to chase the number only, rather we have to interpret the reports in view of the clinical scenario of the patient. It is really important. So why we are so much stressing about the risk of undertreatment, that Addisonian symptoms that can be hazardous, risk of adrenal crisis, allows increased adrenal androgen production, accelerated bone age, loss due to hyperandrogenemia, loss of growth potential, impair individual capacity to respond to stress, adrenal masses, that can be there, testicular, that is star tumor, irregular menstrual cycle due to hyperandrogenemia can be there. And what is the risk of overtreatment? That is Cushing-White symptoms, heterogenic Cushing syndrome, increased blood pressure. So glucocorticoid replacement therapy in CAS leads to overproduction of adrenal androgen, hasten epiphyseal maturation and closure. So early, that is the time to grow in the years is going to be less. And the final outcome is that compromised adult height. Suppressed growth, even minimal overtreatment can impair the growth of children. Osteoporosis and fracture if it is going to be unmonitored. So now coming to the conclusion that what we should do, that despite being a life-saving therapy, conventional corticosteroid replacement therapy remains subjected to the numerous limitations still. Focus should be on side effects acknowledgement in order to raise awareness among clinicians. It is very important. And attainment of guidelines for worldwide uniformity is high priority. Reliable treatment biomarkers are crucial for developing individualized treatment regime and thus improving compliance. Chronotherapy is a promising field, yet it has not been very friendly and may be able to mimic physiological cortisol production in the future. Achieving better pharmacokinetic profile is important for minimizing adverse outcomes for chronic corticosteroid therapy. So thank you so much for your patience hearing, and I hope that I have finished my presentation in time. Yeah, thank you so much.
Yes, sir. Thank you so much, Dr. Vijay. So thank you so much, doctors, Dr. Vijay, Dr. Aniket. We had a great session, and thank you so much again for sharing such great insights.
Yes.
And should we start taking questions, sir?
Yeah, definitely. I think that we should.
Okay. Okay.
Because this is the main crux. After finishing the talk, we have to take questions and really we have to solve the query.
Definitely.
So we'll try to do that.
Definitely. Okay, sir. So first question is from Amit, that what dose of hydrocortisone aldosterone in CAH and who all need it or do all need it?
Yes. Yes. Thank you, Dr. Amit. So Dr. Aniket, you are going to answer or?
No, sir, you can go ahead.
Okay. Thank you. So definitely, sir, thank you for this is really a very important question. So basically, if we going to understand the basic pathophysiology, CAS is an umbrella term. So congenital adrenal hypoplasia, but the commonest, the garden variety, what we can see, that is 21 hydroxylase deficiency. And this is the commonest variety of CAS, but there can be some other forms, that is 11 beta or something. So if whether this CAS is associated with genital ambiguity, with hypertension or something like that, if it is not so, And even if we have not done the genetic diagnosis for 21 hydroxylase deficiency, we assume that the dose initial, that is what the maintenance dose is, 8 to 10 milligram per meter square per day. But due to backdoor pathway and other things, what is the problem is that there is excessive hyperandrogenemia. So to suppress that, initial dose of hydrocortisone may be required even 20 milligram per meter square. So that may be about twice or thrice the daily dose, normal replacement dose therapy. But subsequently, we are going to come down to maintain in a range of 8 to 10 milligram per meter square per day. And how it is going to achieve that, if we are going to add, because most of the patients are going to have some sorts of mineralocorticoid deficiency, whether that can be hidden. And so it will be wiser to add fluoricard, that is fluorocortisone, and or mineralocorticoid in a range of say 100 to up to 200 microgram per day. And of course, initially the pinch of salt, that is about 2 to 5 gram per day in divided doses. And we have to monitor the growth of the baby. This is going to give the answer. I think Dr. Amit.
Yeah. And so the question is continued, like to tell the dose of hydrocortisone in milligram per kg rather than in m square, and also how to calculate body surface area in newborn, like what is the formula for calculating.
Uh, Here again, so body surface area in newborn will be a difficult task. Rather, we have to take in nutshell that in the newborn period, the minimal dose for hydrocortisone requirement is about 10 to 15 milligram per day initially, for about 2 months. So we don't have to use body surface area for that. And later on, it is going to be calculated or titrated in terms of 17 OSP and the clinical outcome of the baby, whether the weight gain is proper or not, what is the PRA activity and other things. So by that, we are going to do that. So there is no need to calculate body area in newborn period because it will be very difficult. And since there are two things what I want to highlight in neonatal period in CAS, that initially there may not be requirement of mineralocorticoid because they are going to have resistance of mineralocorticoid receptors. But later on, they do require for that.
Okay. Okay, so I think the question is answered. The next question is, in babies on hydrocortisone, aldosterone, how often to monitor electrolyte and 17 OHP?
Yes. So as I have already told that 17 OHB is not a gospel truth. We have to monitor the patient in toto. It means that whether the baby is gaining weight, he is not being symptomatic, and he is not gaining weight excessively. That is also important. So usually we are going to do by 2 or 3 monthly electrolyte and weight, and probably 17 OSP 3 monthly. But again, our aim is not to normalize the 17 OSP. If 17 OSP is near normal, it means that we are over treating the patient, and that should be avoided.
I just wanted to add to that, sir.
Yes.
That sometimes if because 17 OHP assays are very challenging and it is not readily available. So those areas where it is not readily available, those patients we can assess testosterone level also, because those assays are robust.
Yes, yes, yes.
That can also give us a guide regarding replacement dose.
So testosterone, if yes, so Dr. Aniket has very beautifully elaborated that if that what it means that inadequately treated, so what is going to happen, that androgen levels are going to rise, and testosterone is one of them. So if it is high, it means that your patient is underdosed, and we have to suppress that hypertestosterone level or say hyperandrogenemia. So you have to increase the dose.
Okay. So the next question is hydrocortisone best given in 2 or 3 doses. What's the best for prednisone?
For prednisone in for pediatric patient, it is a big no. It is never best. It is horrible. Prednisone can be tried only once the child has attained his or her final height potential. Then only we can advise prednisone. Otherwise, no dose pattern is adequate for replacement in CAS for prednisolone. So there is no place for prednisolone replacement therapy in CAS in growing children with CAS.
Okay.
I think all the pediatricians are using prednisolone for conditions which are very commonly encountered, like nephrotic syndrome, and so that's why they are comfortable. But they have to understand that we are using prednisolone for a anti-inflammatory property in these disorders. And what we are right now discussing everything is about physiological replacement of steroid, which cannot be done by high potent steroid like prednisolone or dexamethasone.
Okay. Um, so next question is, what is the timing of replacement with hydrocortisone in adrenal insufficiency due to CH or non-CH causes? And the last dose of hydrocortisone should be in evening or in night?
Okay. So a replacement, Dr. Aniket, will you answer?
Can you just repeat the question?
Yes, Dr. Aniket. The question is, what is the timing of replacement? Like last dose of hydrocortisone should be in evening or in night?
I think evening dose is better because as we just studied our slides in which I have shown you diurnal rhythm of hydrocortisone.
Yes.
It is highest in the morning and then it is moderate in the afternoon and it goes down slowly. So to achieve that or to mimic that physiological dosing, it is always better to avoid giving it in the late in the night, or best is in the evening.
Okay. So next question is, how good is the screening test for CH in filter paper?
Okay. So good question. Though this was not my topic, but again, this is not a very tight compartment. So I can answer that. That we have to understand that whether we want to screen just only for CAH or multiple screening program. So if we are going to talk about filter paper, rather it is going to take care of the commonest inborn error of metabolism. So it is going to include the congenital hypothyroidism as well as CAH. So what is going to happen that after day 3, if you are contemplating for CAH also screening, that is 17 OHP, at least 48 hours, initial 48 hours should not be done. So day 4 or day 5 will be the timing for that thing, because there can be so many biased thing for 17 OHP readings for that.
Okay. So next question is, how much adrenal insufficiency is seen in adrenal hemorrhage in newborns? Is hypoglycemia a common presentation of adrenal insufficiency due to adrenal hemorrhage?
Yeah, actually, can I answer that question?
Yes, yes, sure.
Recently only I have seen this case which doctor has asked. I have seen a newborn with bilateral adrenal hemorrhage, and that baby was admitted in NICU with clinical picture similar to sepsis, and that baby was not responding to sepsis. And in a routine workup, they did an ultrasound, and in which they have found a large adrenal hemorrhage, and the cortisol level was very low along with ACTH, which was very high, and baby was not responding to routine treatment. That's why we started hydrocortisone injection in that child, and baby responded beautifully to this treatment. And yes, adrenal hemorrhage can significantly disturb the adrenal functioning in newborn period and can lead to adrenal insufficiency. And if you get that picture on ultrasound, it is always prudent, even though patient is not symptomatic, to document one cortisol level to sure that this patient is not having adrenal insufficiency.
Yes. Yes, I think well answered. The question is well answered. So next question is, how can electrolytes help in diagnosis of type of CH?
Yes, yes, yes. So electrolyte is basically is important because we have to see for initial presentation of CAS, that is two things we have to see. Initially, babies can present with hypoglycemia because of cortisol deficiency. And second, that is due to some partial deficiency of mineralocorticoid. Sodium is going to be low and potassium is going to be high. So that you can suspect, and you have to see the whole picture of the baby, that is clinical scenario as well as electrolyte parameters, and if it is, and hypoglycemia of course. If it is so, then obviously we should think for suspect for CH. And if this is a female or say any baby who is having genital ambiguity, whether this is male or female, or the healthcare worker is in dilemma, and there can be private part darkening. That is, the baby is not necessarily that the whole body is dark skinned, but the private part, that is genitalia, whether it is overstaining or dark. So there can be suspicion. But again, in the dark skinned country, it is really difficult to say, but we have to compare the baby or the siblings with that parent. So that is going to have some clues.
Okay. Okay, sir. Um, so next question is, how are these steroid therapies adjusted during and after surgical procedure in Addison's disease?
Yeah. So I think we already discussed that stress dosing
Yeah.
is, and surgery, major surgical procedure is a severe
100 milligrams.
physiological stress, and that patient may require almost 4 or 5 times of the physiological dosages, around about 100 milligram per meter square per day. And remember why these dosages are so high in a stress is we want to uh, give effect which is equivalent to both glucocorticoid and mineralocorticoid.
Agreed.
So
Okay.
giving hydrocortisone in such a high dose will also cover the mineralocorticoid replacement in these patients, because unfortunately there is no IV mineralocorticoid which is available. So we have to take care of both parameters, and the way in which it is done is by giving very high dosages of hydrocortisone during stress,
Yes.
pre-operatively and post-operatively. And as the patient stabilizes, we can just go back to the routine schedule of replacement.
Okay.
This is not only applicable for CH, but this is applicable for those patients who are on chronic steroid therapy.
Okay.
Adrenal insufficiency as a whole.
Yes. Okay, sir. So, next question is, what are the indications for surgical intervention in the treatment of CH?
Actually, this topic is not. Yes, so what I can answer that so there are two school of thoughts. The liberal one, what they say, that unless and until whatsoever the anxiety of the parents for the sake of society, we have to see the acceptability in the society. So that can be, the answer can be variable depending upon the social scenario. So basically, what is problem in India or say developing world, that gender variation. So you 99% you know that in a female baby who is looking like male in the initial presentation, and you have done all the initial workup, and the parents are having a phase of denial that नहीं ये तो मेल बेबी है और इसको मेल ही रखने के लिए डॉक्टर साहब क्या करना है. So again, this is not a job of only pediatric endocrinologist or say neonatologist. This is a teamwork. And we have to tell them that, look, this is, if we are sure that this is due to genital ambiguities due to CAH, so this is a girl child and we are going to treat. There is no hurry to resect or say amputate that stump, that is clitoromegaly or say phallus. And because you are not going to take any consent for that particular child who is the sufferer. So basically, the new thing is that we have to postpone therapy surgical treatment unless and until the disease is very severe and the parents are in very real agony. Otherwise, now they say that we have to take the consent, and consent, how the child is going to give consent. Rather, it should be appropriate to understand the process, that what is going to happen with his or her body. Then only probably it will be justified to do CA surgery. So there are two type of surgery. One is definitive surgery and one is say cosmetic surgery. So for the sake of cosmetic surgery can be done earlier, but definitive surgery should be discussed, should be taken care with probably consent of the patient or the sufferer itself, not only the family members. So it is really important.
Okay. Yes, sir. So next question is, for dosage titration of steroids in children with CH, what do you rely on more, like growth chart or biochemical markers?
I think we both will agree that it is a growth charts.
Okay.
Because
Yes.
already under stress, that is a clinical monitoring, and biochemistry will guide us or help us as a added therapy. But the main decision making of a titration will be based on growth charts.
Okay. So the answer is clear. I guess yes. So the next question is, what dietary restrictions are helpful in the treatment of CH?
I don't think there is any dietary restriction which is advised or specific diet which is advised in CH. Only thing is that already, as Vijay sir has under stressed, that the absorption of hydrocortisone in fasting or in fed state or with respect to food, it is not documented to be very different. And even in individual patients, it is the same dose will have different effect or absorption. So it has been studied extensively in patient population, not only in normal but in CH patients, that how is the absorption and what are the cortisol levels after giving hydrocortisone, and they are very variable. That's even we are trying to mimic a physiology, we are not near normal to that because of this problem. So no dietary restriction as such, but only duration in between the dosages is important right now, which we can do to replace the physiological effects.
Okay. I think, sir, we have one last question.
Yes.
What is an indicator of excess exposure to glucocorticoids in the treatment of CH?
Yes, definitely. One is clinical monitoring. If you are going to monitor the child, if there is weight gain or excessive weight gain, but the height is not improving, it means that you are the baby is, or the patient is landing up in the Cushing guards, that is excessive dose of corticosteroid. And we have to monitor the level also, that how the 17 OSP is going, what is the blood pressure and other things. So that are, and pseudo hum phenomena can be there, but early suspicion is really required. So to develop a Cushing guard picture, bookish picture, it will take time. So it is better to monitor that even before compromise of the height. If growth velocity is going down and weight is going to increase, it is itself suggestive that overdosing of steroid is going to happen.
Okay. Okay. I think, sir, all the questions have been answered, like what all doubts we had in Q&A and chats also. So I thank you so much, Dr. Vijay and Aniket. And I think I can hand over the session to Prashant.
Yeah. Thank you, Dr. Vidya.
On behalf of Samarth Life Sciences, I'd like to offer the vote of thanks. Firstly, it has been a very engaging session on adrenal medicine and equally informative, educative, and enlightening Q&A session on both the topics covered in today's webinar, that is adrenal insufficiency beyond CAH and corticosteroid dosing in CAH, walking on the tightrope. My heartfelt thanks to Dr. Aniket Kumbojkar and Dr. Vijay Jaswal for helping, guiding us, and chairing this session under the banner of Endo-Physician Interconnect, that is EPIC. We really appreciate you taking time from your busy schedule for this scientific session. Also, I would like to thank Dr. Divya for helping and supporting us by moderating the session. Lastly, I would like to thank all the delegates for sparing time from their busy schedule and attending this webinar. We are looking forward for your participation in our series of webinars on adrenal medicine. A big thank you to all of you from Samarth Life Sciences family, makers of Hyzone and Floricort, that is hydrocortisone